Andrew, can you tell us a bit about how MPNs are diagnosed?
Yeah, so MPNs can be diagnosed really as far as the journey to diagnosis can happen in a variety of ways, whether that comes with abnormal blood counts that are done at a primary care office or just as routine that show an abnormal blood value that then results in a hematology referral and further workup. It can also arise from patients having new symptoms that are concerning, whether that's something kind of vague like fatigue or abdominal discomfort, or could be something more severe like fevers, chills, night sweats, bone pain, weight loss that's unexplained that might drive them to have this looked at. But ultimately, as far as achieving that diagnosis, it requires really a mixture of things. So certainly the history, the clinical symptoms matter. The physical exam may matter to identify an enlarged spleen or maybe enlarged liver or lymph nodes that may be enlarged as well. You combine that with blood counts that show abnormalities and maybe some immature blood cells floating around in the setting of myelofibrosis, or too many platelets or too many red blood cells, maybe too many white blood cells as well. But I think that's all kind of secured with a bone marrow biopsy, which really is the standard for achieving these diagnoses. As ultimately, this is a problem with blood cell production. It's a problem with the factory, and the factory is the marrow, right? And so to really get a sense of what's going on, it takes a biopsy of the bone marrow where we can see that activity that's going on. Too many megakaryocytes, odd-shaped megakaryocytes, too many other blood cells, maybe fibrosis, scar tissue, clustering, thickening of the bone. All of these things really can be viewed through the lens of a bone marrow biopsy and an aspirate, where we get to look at those individual cells. All of that's really helpful to tie things together, but I think really the cherry on top, and what's really been really helpful over the past 2 decades, is that we now have genetics to show what's the actual mistake that's driving these abnormalities. And there we can do a variety of different tests to look at gene sequencing, and we can see mutations in JAK2, CALR, MPL. These are driver phenotype driving mutations that lead to this. And we see that in 90% or more of patients. And that really helps to secure this diagnosis and let us know that the bone marrow findings, the peripheral blood findings, the symptoms are really due to an underlying genetic mutation that's driving this process.
Are there times when the diagnosis can be a little challenging? Say when the genetics is unclear, or maybe the bone marrow biopsy is not quite what you expect?
Yeah, I think there's certainly times where the diagnosis can be a bit challenging. I think we mentioned that the cherry on top is these genetics, and I think sometimes we become a little bit over reliant on these genetics, and we're put in a difficult spot when they don't come back like we expect. And so 90+% will have a driver mutation, but in that maybe 8% or so that don't have a classic driver mutation, I think you have to take a step back and think about, is there an alternative cause for fibrosis in the marrow? Is there an alternative cause for these abnormal blood counts? Maybe doing a broader gene sequencing panel to identify less frequent, less common mutations that can establish that this is truly a disease of the bone marrow. But there are some kind of mimickers, right? And one example I have, I mean, you could have hairy cell leukemia, right? So this is a lymphoid disease actually that can show up with fibrosis and a big spleen, but may not have the classic driver mutation, may actually be driven by a different mutation. And so I think that we have to kind of take a step back when things don't look exactly as we'd expect, and really consider a broad variety. Additionally, as you'd mentioned, there's times where things look like they have overlapping features of different MPNs. Does this look like more like polycythemia vera? Does this look more like ET? Blood counts may show one picture, but bone marrow may show something that's different. And I think it's important then to realize that, we created the names of these diseases. The disease doesn't always read the textbook, and these diseases can exist on a spectrum. So you can sometimes describe things as being in between, or having features of both. And I think that's important as well. I think the last example I would have is the emergence of a new diagnostic entity that we created called prefibrotic myelofibrosis, where maybe the bone marrow looks like an emerging myelofibrosis, may lack some of that scar tissue, but the cells look like myelofibrosis. But when you look in the peripheral blood, it may not necessarily look like that. You may see just high platelets, but clearly, if you look in the bone marrow, this doesn't look like ET per se. And so I think these are kind of nuances with the diagnosis that exist. And we're trying to grapple with that and put names on it, and better understand these diseases, but there are sometimes some challenges that emerge.
Fortunately, they apply to a minority of patients. Most patients um, can be quite easily diagnosed with a combination of bone marrow, blood counts, and genetics as polycythemia vera, essential thrombocythemia, or myelofibrosis.
Absolutely, definitely.